Thank you. Thank you, Dr. Partha. At the outset, I would like to thank him for inviting me, for giving me this opportunity to share my view on phakic oil. I am doing this since 2007 and I have no financial interest. And it's a good option and safe option for basically LASIK rejects. And it allows the crystalline lens to retain its function. There is less risk of vitreoretinal side effects of clear lens extraction like retinal detachment, and there is a faster recovery and healing, does not cut or remove corneal tissue, and cornea retains its natural shape. There is less glare issues on patients with even with large pupils, very stable over time, and there is no regression. But there are certainly some limitations which are there with any intraoperative surgical procedure. But mind it, they are not very great, and there can be surgically induced astigmatism, endothelial cell loss, iris ovalization. But with ICL, these all problems are minimized. This is in general for all phakic lenses. There are variety of lenses which were available and which are still available. Angle supported phakic lens, iris fixed phakic lens, posterior chamber phakic lens. And the history says that the quest for this has been there since 1953 when Strampelli lens came into picture. But all these lenses which are available has become a history now. This is Nuvita lens which has been recently come into this thing, but with unacceptable results. Vivarte, unacceptable results. iCare. But I will focus mainly on the current designs available. This is the iris fixed very size lens, which Dr. Ramamurthy has also shared. This is our lens which we did in 2003, 2004, and this you can see this lens has gone down on one side because of partly disenclavation of this lens. So this lens is again a FDA approved lens for myopia. It is made up of PMMA, highly predictable and relatively safe, but large incision is required, and there is a chance of progressive endothelial cell loss and glare in higher effective error corrected patients because the lens size, optic size decreases, and there is a problem with disenclavation. It's a foldable version is also available, but it is not FDA approved. Then Acrisoft came out with Cachet phakic lens, and it's not FDA approved. It is CE marked. Single piece acrylic foldable lens, and easy to implant. There is no need for iridotomy, fast visual rehabilitation. But again, this has not gained popularity. This is the lens I should say, which is in vogue and very, very popular and with very predictable results. It is made up of polymer material which absorbs UV radiation with the central vault, foldable lens, and there is a sizing issue which can be taken care of if the surgeon is very, very careful. So the present day lenses which are available is ICL, which is FDA approved, Verisize, again FDA approved, Acrisoft Cachet lens, which is CE marked only. Now coming to my second part of the talk, that is how one should go ahead and do the workup. Before that, I would like to highlight something about the material, which is unique in its kind, which is a biocompatible. As the collagen attracts a layer of fibronectin, so this acts and inhibits the deposition of other proteins on the surface of the lens. Thus, polymer lens is not recognized as a foreign body. So this is the best part of it, and it remains clear as long as we have seen. We have been doing it for since 2007. It has a better optical performance, less glare than halo because of the polymer material, and it is very flexible. So implantation and explantation is easy, and it can be injected through a small incision. Now availability range has increased. It is now available right from 0.5 to -18 diopters, and in toric from 0.5 to from 0.5 to -18 with up to +6 diopters of cylindrical correction, and in 0.25 steps in cylindrical power up to 2.75 diopters. So this is the good news which I would like to share, because very many people over here must be knowing that it is available from -3 diopters upward. So preoperative assessment is very, very important. A complete ophthalmological assessment is done, uncorrected, when best corrected, visual acuity, refraction, slit lamp examination for each and everything, right from cornea, then lens, anterior chamber, angle, etc. Intraocular pressure, fundus examination thoroughly has to be done. If any peripheral lesions are there, they have to manage preoperatively. Anterior chamber depth measurement is very, very important. Sometimes in myope cases also we see that the anterior chamber depth is less than 2.8, and 2.8 is the benchmark. Below this, one should not use ICL, and one should go for LASIK, as Dr. Partha has already shown beautifully in his tree, apple tree, which has been shown by him. The corneal topography and keratometry to rule out any corneal pathology. And another important and very, very important thing should be kept in mind is the measurement of horizontal wide to wide distance. So this is where I would like to emphasize more, that sizing is an issue. Most of the cases of complications, they are because of the poor wide to wide measurement, and sizing is inaccurate sizing of the lens which has been implanted. It can lead to cataract formation, it can lead to glaucoma. The accurate preoperative wide to wide and anterior chamber depth measurement is important. And ICL provides a vault, as you can see here. This is the distance between the clear lens and the ICL. And ideal sized ICL gives a vault of 0.25 to 0.75 millimeter. And this can be easily seen on slit lamp compared to the corneal thickness, which should be half to 1.5 times the corneal thickness. If you take the corneal thickness as 500, the minimum vault should be less 250, maximum 750 micron. Undersized ICL less than 0.125 millimeter vault, there is an increased risk of anterior subcapsular cataract, and we should be very, very careful and do the regular follow-up. And in oversized ICL more than 1 millimeter vault, this pushes the iris forward and closes the angle, which could lead to rise in intraocular pressure. This should always be kept in mind. And how we should measure the wide to wide horizontally, it is done in a supine position under the microscope. This is a digital caliper, as you can see, and a clear corneal measurement is done at the horizontal meridian at the limbus. Now coming to the new ICL, which has a specific design which has been shared partly by Dr. Partha also. It has a centraflow ICL which belongs to the ICL V4 family, and V4B is it comes in the dehydrated form and normal form. It is not dehydrated because it is now available in BSS, and the size is slightly bigger than what it used to come before. And there is a central port of 360 micron in the center of the lens, and in diameter. It is designed to restore more natural aqueous flow, as you can see, and eliminates the need for the iridotomy, because most of the problems were during the surgery were due to the iridotomy, and that could be one reason, because of the aqueous flow was not regular or normal. That could be the cause for the formation of lens changes. A 360 micron perioptic ports are designed to facilitate OVD removal and provide redundancy for the central optic port. In case if the central optic port gets occluded, there are two perioptic ports of same 360 micron, and 360 micron is the ideal size or the ideal diameter of the port, which will not give any glare halos, and at the same time it will not decrease the quality of vision, and at the same time it will provide a good quantity of aqueous without a gush to damage the endothelium and from the posterior to the anterior chamber. So this is the beauty of this design. Peripheral iridotomy, which used to be done earlier by YAG laser or surgically, still in shallow chambers, when the 2.8 millimeter chamber, rarely I do iridotomy. In one case recently I did iridotomy to be on the safer side. This is coming to the Toric ICL preparation. One can mark, I am marking a horizontal meridian 3 and 9 o'clock clock on this slit lamp. I am doing it with the left hand, and the marks will be seen like this. And or you can mark the way we do with the Toric IUL with the bubble marker, and these marks, after trying, you can take the patient for the Toric ICL implantation. This is the sheet which comes, and you come to know that you have to rotate the lens clockwise 17 degrees, and this is the intraoperative marker, and you can align the lens with this. Preoperatively, the patient should have a large full-size dilated pupil of minimum 8 millimeter dilation. It is done under topical anesthesia, or one can do it under retro or perivalvular anesthesia if they feel like to be more comfortable. And draping and speculum is done in the same way as we do it for any other routine surgery. Normal sterile technique is adopted. Lens loading is done, and tucking the side of the lenses of the ICL into the side groove. This is the ICL cartridge, and we fill the cartridge to some extent with the BSS, and then with the methyl cellulose, and the lens is taken out from the bottle. This I am showing earlier picture. Earlier we used to load the lens first, and then the patient is taken inside. This can be done for the initial cases, and so that the patient doesn't get apprehensive if you are taking more time, or if you are discussing with someone while loading it. And with the front loading technique, with the coin-shaped forceps, the lens is held and it is pulled. The cartridge is moved towards the left side, and keeping the forceps steady, and this will prevent the damage to the thin lens. And the cartridge is now loaded in the injector system, and you check the forward movement of the lens here, and advancement of the plunger to push the ICL into the view of the cartridge barrel is done, and then you can switch on to the patient. And a clear corneal tunnel 3.2 millimeter by 1.5 to 1.75 millimeter is made. Paracentesis are made. OVD from peripheral towards center. This is different because we in cataract cases we inject from the distant place. Here we inject the OVD from the periphery because the lens is still there. And avoid overfilling of anterior chamber. This is very important because the lens will not unfold properly into the anterior chamber if it is overfilled. And inject 75% of ICL slowly. Cartridge tip should be away from the pupil center. It should not go inside the wound. Otherwise, you can damage the crystalline lens. Allow the leading haptic of the ICL to unfold. Then wait. Inject remaining 25% of the ICL then. And then the OVD is removed. And 2 tablets of acetazolamide are given. This is a Toric ICL. We are marking the placement of the lens. Fill the chamber with viscoelastic. Push the cartridge into the wound, not within the wound, just at the brim of the wound. And it unfolds automatically. You don't have to do anything. Just wait. It will unfold naturally, normally, in a right way. And then you can tuck it easily with this manipulator. And you can mark it. Yeah. So, 2 hours post-operatively, intraocular pressure has to be checked. If intraocular pressure is more than 24 millimeter mercury, that could be retained viscoelastic, or the iridotomy is not functioning, or there is a shallow. If there is a shallow anterior chamber, there is a chances of high vault and angle closure. ICD should look deep normally. Check pupil and ICL centration at 2 hours, and check ICL vault. Low vault is common in the earlier cases. We used to get low vault. Antibiotic and steroid drops are instilled, and oral NSAID is prescribed. Post-operatively, we give the NSAID and steroid drops and antibiotic drops. Steroid drops are given for a month, 4-3-2-1, and antibiotic for 10 to 15 days only. This is post-op Pentacam image, and this is what I would like to share here. Thank you.